Hi there, and welcome to an important discussion on breast cancer screening and why it's critical that women start screening at the age of 40, and also why it's so important to recognize the importance of breast tissue density. My name is Lucy Van Olden Barneveld, and I'm a journalist here in Ottawa. I was diagnosed with breast cancer in my 40s, and so was my younger sister, and we had no history of cancer in our family whatsoever. You know, current guidelines for breast cancer screening are not up to date, and this is having an impact on women. So we decided to talk about it, to bring together 4 experts in breast cancer screening to explain the current science and also to make recommendations on guidelines that family physicians and healthcare providers should be following. And we hope that they will be following to make sure that breast cancer is detected early, giving women the best possible outcomes. So how it's going to work over the next 20 to 25 minutes or so is that I'll introduce each of the panelists, and then we will make our way through a series of questions. So let's get started. Dr. Anna Wilkinson, she's a GP oncologist. She's with the Ottawa Hospital Cancer Center as well. Dr. Wilkinson, maybe we can start with just going over the guidelines. What are they? What are the current guidelines?
Sure. So in 2018, the Canadian Task Force on Preventative Healthcare updated the guidelines for breast cancer screening in average risk women. And so in a nutshell, those guidelines are for women who are 40 to 49, that there be no breast cancer screening. For women aged 50 to 74, the guidelines are to screen with mammogram every 2 to 3 years. They also recommend no clinical breast exam, and there's a recommendation against breast self-exam that's low certainty evidence. The other recommendation they make is that physicians consider women's values and preferences around screening when deciding whether or not to screen.
You know, my next question, I think you've already answered by talking about what the guidelines are, because some of them seem almost unbelievable in many ways. So how would you describe the problems with these guidelines?
So I think to look at the problems, you need to understand that guidelines are only as good as the evidence that they're based on. The studies that they're basing the mortality benefit on for breast cancer were done, the earliest study was 1963 and the latest study was 1991. These are randomized controlled trials they based them on. So basically we are informing our decision on breast cancer screening in 2020 on an RCT, or a randomized control trial, that was started in 1963. So if you think about that, that's 6 years before we landed on the moon.
So my exposure to these guidelines and the practical clinical side of these guidelines is twofold. So when I look at it from the family physician perspective, what I see is that women in their 40s aren't being offered screening by family physicians. And this is really because although the guidelines suggest we should be looking at values and preferences, because they say that we should not be screening, family doctors are not even entering into a discussion the majority of the time with their patients who are in the 40s. And if these women do bring it up, very quickly the family physicians inform patients that this is not recommended in the guidelines. From the oncology perspective, when I work on the oncology wards, I see the mortality of this firsthand. And what I see is young women in their 40s not infrequently dying. And so I challenge you to put your feet in my shoes, to be the one speaking to a woman's teenage sons as she's dying from liver failure from her breast cancer, letting her sons know that she has only days to live. I challenge you to be the one sitting beside a woman who can't catch her breath because her lungs are filling up with fluid from her breast cancer as she's dying. I challenge you to be the one to be trying to console a patient's husband who is inconsolable as his wife has just died. These women were all women I've cared for in the last year who were in their 40s, and I can't help but wonder if the guidelines were different, if people were screened, whether these deaths would happen. So those mortality figures that we're looking at, they're not just abstract percentages or numbers, they're actual real people. And so I think we really have to think about what we're recommending in these guidelines.
So let's try and understand where these guidelines come from and who is making them up. Dr. Jean Seeley is the head of breast imaging, professor of radiology at the University of Ottawa. Jean, maybe we can pick it up there. Who are the people on the task force panel who make these guidelines that Anna was just telling us about?
So Lucy, the task force was selected so that they specifically had no expertise in breast cancer. They could not have been involved with breast cancer diagnosis, treatment, or management. They were specifically selected for experts in methodology for research, and that included epidemiologists, public health nurses. It also included a chiropractor, an occupational therapist, a psychologist, and a nephrologist to be on this task force. The task force really ignored international guidelines that says that anyone who should be on a guideline committee should involve experts. And there is not one expert on breast cancer in that task force.
This task force of the people that you're describing there are making the rules for whether or not, making the guidelines for whether or not women in their 40s should get tested. I mean, this is almost, it's really hard to get your head around, especially as someone who's been through breast cancer. And my sister, who was younger than me, was diagnosed at 46, and she died 18 months later. And if either of us had been following these guidelines, who knows what the rest of the story would be for our family. So Jean, why is it important for physicians to discuss screening with patients in their 40s?
Well, I think the critical point is that women in their 40s get breast cancer. We know that of all breast cancers, 20% occur in women in their 40s. We know that 20% of the women who die from breast cancer are in their 40s. And we know that the number of life years lost is in a third of women who are in their 40s. So this is a huge loss of life due to breast cancer, and they get breast cancer, as you've so eloquently spoken of.
So then why did the task force not recommend screening for women in their 40s?
They were, as Anna mentioned, they based themselves on out-of-date randomized controlled trials. They ignored key evidence that we have that breast cancer screening works in women in their 40s. There is a large pan-Canadian trial that was published in 2014 that looked at over 2 million women who had been screened. And they could show that in women who were actually screened, 44% reduction in breast cancer mortality occurred in women in their 40s. And that was slightly better than the mortality reduction in women who were in their 50s, 60s, and 70s. So because they didn't have experts and because they didn't follow international guidelines on who should be involved in making guidelines, they ignored critical evidence that supports the reason why we believe screening in the women in their 40s is so important. The other point that is really important, Lucy, is that women who get screened are less likely to die from their breast cancer, but not only that, are much less likely to need more extensive surgery. They're less likely to have their breast cancer spread to their lymph nodes, and so they're less likely to have more extensive therapy. It costs less if they're diagnosed early, and they have far better outcomes.
Right. The task force, though, and I've heard this reason for not screening earlier come up before, that there can be harm coming from screening in the form of false positives, that is just too stressful.
So the problem with the task force, because they didn't include experts in breast cancer, they overemphasized the harms. They exaggerated the impact of an abnormal recall from a mammogram. If you have 1,000 women who are recalled who get screened, there will be a small number of women who get recalled because of an abnormal screen, and the vast majority will be reassured at the time of an extra mammogram or an ultrasound. Only 8% of women who get recalled will actually go on to a biopsy. And so it's a very small number. And I can tell you, the women in our practices are never upset about having an abnormal recall. They're never upset about us having to do some extra reviews. In fact, they're more likely to participate in screening after those abnormal recalls. It's the women who have a delayed diagnosis of breast cancer that are the most angry. And they are so angry at the task force telling them not to benefit from screening.
You know, as I understand it, there are differences in provinces across the country in what age they recommend screening to begin. So where does that leave physicians on whether or not they can recommend that a patient in her 40s should go for screening?
Any woman in her 40s across Canada is allowed to have a screening mammogram. So with a requisition from her physician, she can be screened in any province. Some provinces like British Columbia, Prince Edward Island, Nova Scotia actually include women in their screening program. So they're invited and they get to have their screening in a provincial screening program, which is by far the best option because women get reminded and they get their regular screening. But any woman with a requisition can get a screening mammogram in Canada if they're in their 40s.
Right. And we'll talk about this with Paula Gordon shortly, just how also important it is if a woman has dense breasts and why that is critical. But before we leave you, Jean, how often do experts recommend that women should go for mammograms, and until when should they go for mammograms?
Lucy, women should start screening at age 40, and screening every year saves the most number of lives from breast cancer. Women in their 40s should screen every year, at least until menopause. After menopause, most women should continue with screening every year. We recognize it is a compromise, and in some women with no added risk factors, they can be screened every 1 to 2 years. But recognize that most women who get breast cancer, 75%, do not have any risk factors for breast cancer. So screening every year saves the most number of lives. The question of when to stop screening is really dependent on a woman's health. So long as a woman is in good health, she should continue screening. If she has competing illnesses or her health means that her life expectancy is less than 5 to 7 years, then she should consider stopping. It's really important that this decision be made as a shared decision-making process with the family physicians and the patients, and that the benefits and the risks be discussed with each patient, and that they make a joint decision together.
To clarify, not only are you recommending more screening for women in their 40s, the guidelines say no screening, you're actually recommending more, just to underscore.
Yes, absolutely. And I know that we'll hear more about it, but that's what we know saves the most number of lives. Okay. And that's why we're doing this.
Yes, absolutely. And let's hear now from Dr. Paula Gordon. She is a clinical professor at the University of British Columbia. Paula, maybe you can describe for us what breast density is and what are the categories?
So breast density refers to how much normal breast tissue there is relative to fat. All women have fat, glandular tissue, and fibrous tissue in their breasts. Fat on a mammogram looks dark, and normal breast tissue, both glandular and fibrous tissue, are white. So white means dense. And every woman is unique. Some women have almost no dense tissue and they're entirely fatty. Some women have a little bit of dense tissue, more. And then there are women who are completely dense with almost no fat. So radiologists use 4 categories. A is the almost entirely fat. B is scattered fibroglandular density, so a little bit dense. And both A and B are considered non-dense. Category C is heterogeneously dense, and that's getting more dense. And then there's extremely dense, category D. So categories C and D are dense breasts. And the reason that's important information is that not only is normal breast tissue dense on a mammogram, cancers and other lumps are white or dense. So as women get into the higher categories, we know that a cancer could be hidden on their mammogram and we may not see it. That's the first risk of having dense breasts. The second is that having dense breasts is an independent risk factor for getting breast cancer. So these women have what we call the double whammy. They're at a higher risk of getting breast cancer, and we might not be able to see it on their mammogram.
So what are you recommending then for women with dense breasts? Extra screening, and what would that look like?
So all women should have mammograms, even women with very dense breasts. Everyone should have mammograms. And you've already heard that annual mammograms starting at 40 save the most lives. But women with dense breasts don't benefit as much from mammography, and they should have a supplemental test, usually ultrasound. But for women who are at very high risk, like women with the breast cancer gene or women who've had radiation to their chest to treat a lymphoma, they should have MRI. So knowing a woman should know her breast density, and then she and her family doctor looking at the rest of her history. What else is important? Does she have a strong family history and so on? Does anybody in her family have the breast cancer gene? They can decide whether her extra test should be ultrasound or MRI.
So if a physician receives results that the patient has density category C or D, what should that physician do?
So I just want to say not all provinces are including that information in the screening report. And we're working very hard to get more provinces to do that. But if the physician gets the C or D in the report, they find out that their patient has dense breasts, they absolutely should initiate a discussion with that patient, find out what other risk factors she has, because there are some things we can all do to reduce our risk. For example, we know that staying at a healthy body weight after menopause reduces the risk of getting breast cancer. We know that regular moderate exercises reduce the risk of getting breast cancer. And unfortunately, we know that alcohol is a risk for breast cancer. So if a physician gets that C or D report, they should discuss what the woman can do to reduce her risk amongst just lifestyle behaviors, and then talk about whether she would like to have supplemental screening.
And let me ask you this, why do you think the task force did not recommend extra screening for women with dense breasts?
So the reason the task force didn't recommend supplemental screening for women with dense breasts is they claimed that there was no evidence to support it. In fact, we have over 25 years of data that shows that when women with dense breasts have supplemental ultrasound, in addition to screening mammography, we find an additional 3 to 4 cancers per 1,000 women screened. That's about the same number of cancers we find using mammography, except in this case, these are cancers that were missed on the mammogram. So we're essentially doubling the cancer detection rate. And the cancers we find are small, they're invasive, they're real cancers, and they have not yet spread to the lymph nodes. So it's super important to find them then. The task force only considers evidence if it's from randomized trials. And there is a randomized trial ongoing now in Japan. It'll take several more years for the final results, but they are already showing that women with dense breasts who have mammograms and ultrasounds, the cancers they're finding are smaller, they're not yet spread to the lymph nodes, and very importantly, those women have fewer interval cancers. And if you recall, interval cancers are the ones a woman discovers as a lump after her last mammogram was negative. And those interval cancers are far more common in women with dense breasts than in non-dense breasts. It's also interesting, the task force says that they will only consider data from randomized controlled trials when they're talking about benefits, but they're willing to consider much lower evidence when they're looking at the harms of screening, even questionnaires. And so that's a little bit inconsistent.
Paula, the guidelines don't recommend self-exams for women. I can't believe I have to ask this, but why are they important?
For the reason I just gave. Sometimes that's how cancer is found.
Yeah. And I should say, self-exam was the way how I found my cancer and how my sister found her cancer. And nobody was telling us to do it. In fact, I had read those guidelines to say, hey, guess what? We don't have to do it anymore. Excellent. So it was sort of inadvertent. So you make an excellent point, and physicians can play a big role in encouraging their patients to do that. Okay, thank you for that. We're going to hear now from Dr. Martin Yaffe, who is a senior scientist at the Torrey Family Chair in Cancer Research at Sunnybrook. Martin, the task force emphasis is on harms rather than benefits. And one harm that they mentioned is overdiagnosis if we had women going in their 40s. What is overdiagnosis, and what proportion of cancers are overdiagnosed?
Lucy, the task force probably means overdetection. Screening is done by a radiologist, and they detect cancers. The cancers are actually diagnosed by a pathologist after a biopsy that's most frequently done by removing a core of tissue through a needle. What the task force are referring to is that some cancers are not aggressive and would never appear if a woman didn't have that cancer detected by screening. Screening finds cancers earlier, and without screening, a woman might never know about those cancers before she died of some other cause. The task force considers what they call overdiagnosis to be a major harm. And they claim that 40 to 50% of cancers may be in this category. But the best analysis suggests that this may really be about 5 to 10% of cancers, and mostly these are the ductal carcinoma in situs. The task force implies that women don't need to know about these cancers, but they're real cancers as far as any pathologist can tell. And if they're detected, of course, those women will receive treatment, and therefore this treatment may not be necessary and could be considered as over-treatment. But the reason for screening is to find the aggressive cancers earlier so that they can be treated effectively, possibly saving a woman's life and sparing her from being treated for advanced disease. And often, by finding the cancers earlier, the woman can avoid receiving harsher therapies such as mastectomy, chemotherapy, or axillary dissection. The task force doesn't even look at these benefits of earlier detection. Now, there's really no way to know in advance which cancers are the aggressive ones and which will be slow growing. So if we want to save lives and spare harsh treatment, we must find the cancers earlier by screening. And the task force has both overestimated the number of cancers that are overdetected, and as well, they have absolutely no idea as to how much overtreatment, if any, is taking place.
We've heard this come up a few times already during this discussion. The task force has said the reason they do not have experts on the panel is because experts are biased, says the task force. Do you think that having experts on a panel, on this panel, generates a bias towards screening?
I think that having experts on the task force will result in its better appreciating the evidence supporting the benefits of screening and putting those benefits in perspective relative to any potential harms. I think that if the task force had utilized the knowledge of experts in breast cancer and in breast cancer screening, its recommendations would have been very different, and many breast cancer deaths and considerable treatment of advanced disease could have been avoided. I know of no other activities in society where it's considered to be a good idea to avoid having people who actually are knowledgeable about a subject involved in discussions that depend critically on such knowledge. Experts may have conflicts of interest, and when that occurs, they must be disclosed, but in such cases, there are well-established procedures available to avoid bias in decision-making.
Just by way of a last question to you, Martin, can you just put a fine point on this? What has your research shown about harms versus benefits of screening?
For women 40 years and older, the benefits that come from routine mammography screening greatly outweigh the potential harms. And some of those harms have not yet been proven to be real harms. The task force has provided misleading data on the performance of screening. For example, for women in their 40s, they've overestimated the number of women required to be screened by a factor of 3. That means that screening is actually 3 times more efficient than the task force says it is. Currently, I'm most concerned by the harms of the task force recommendations as they exist. If they are followed, for women between 40 and 49, not screening those women, 400 to 700 Canadian women will die of breast cancer each year. And these are deaths that are preventable by screening. Some women who are well above average risk or have very dense breasts will almost certainly benefit from supplemental screening with breast MRI, ultrasound, or contrast-enhanced mammography. And the task force has totally ignored these women.
Okay, I think we'll end it there, Martin. Thank you that's a powerful point to end on. And I think what we are hearing is that until the guidelines are changed, until the task force is looked at again and reformed, that physicians can have a big role, a big and important role to play in the advice that they give to women to get screened early. What we've heard tonight is that the benefits of screening far outweigh the harms of false positives and overdiagnosis to a ratio of 8 to 1. That there is indisputable peer-reviewed evidence by internationally respected organizations that mammography contributes to saving lives from earlier detection of breast cancer. That women should begin mammograms in their 40s and go annually until they hit postmenopause. That the evidence shows that studies that women whose cancers are found small through screening can be spared the misery of chemotherapy or the need for removal of an entire breast or both breasts. That women with dense breasts face 2 risks and can benefit from ultrasound to find cancer early. And that self-exam is an important tool for women in breast cancer detection. So I think with that, we will wrap up our panel tonight. And I want to thank all of our experts tonight for their informative, thought-provoking discussion. And I hope that physicians and healthcare professionals who watch this find it useful and helpful and can advise women to get screened and to get screened early. Thank you.